أهلا بيكم. Today we will study the posterior mediastinum. So let's start. The posterior mediastinum, we're talking about this area. Okay, it's posterior to the pericardium and anterior to the vertebral column, the lower vertebrae actually. And by studying the posterior mediastinum, we will conclude the study of the inferior mediastinum because it's part of the inferior. We're not talking about this area here. No, we're talking about only this area, which is superiorly bounded by a plane passing through the angle of Lewis, the second costal cartilage, and the disc between T4 and 5. Inferiorly bounded by the diaphragm, anteriorly by the pericardium, posterior by the vertebral column, at the sides by the mediastinal pleura. Structures in the posterior mediastinum: the esophagus, the esophageal plexus, formed by the vagi, the thoracic aorta and branches, we mean the descending thoracic aorta, of course, the azygous system of veins, we mean the azygos, hemiazygos, and accessory hemiazygos, the thoracic duct, the main lymphatic channel in the body, and the thoracic splanchnic nerves, the nerves that we studied before as branches of the sympathetic chains. You remember those coming from the lower ganglia of the sympathetic chains, and we learned before that the sympathetic chains themselves, see, they are outside the posterior mediastinum. Posterior mediastinum should be in front of the vertebrae. The sympathetics are outside the posterior mediastinum, while the splanchnic nerves, as you can see here, see those? They go to the anterior part, anterior to the vertebral column, so enter the posterior mediastinum actually. Okay, so let's start with the contents. The esophagus, we studied in the head and neck that it begins as continuation of the pharynx level with C6 and descends behind the trachea, slightly shifted to the left. We learned this before because the narrow thoracic inlets, so structures are displaced a little. And to remember this, the esophagus goes to the stomach, which is on the left, so it is the one on the left posterior and left to the trachea. By the way, in this specimen, it should be part of the esophagus should show up here. Okay, it crosses from right of thoracic aorta. It was on the right thoracic aorta first, then becomes anterior, then leaves it and goes through the diaphragm. And the thoracic duct was posterior to the esophagus, then to the left side, ascended posterior to the esophagus, then to the left side of the esophagus. And it's crossed anteriorly by the bifurcation of the aorta and the right pulmonary artery and left main bronchus, actually a little lower down. Then the esophagus becomes posterior to the left atrium, and we discussed this when we studied the serous pericardium, the sinuses in the sinus pericardium, the transverse and the oblique sinus, and we said that the oblique sinus directly behind it is the esophagus, and it can be compressed by left atrial hypertrophy, so it's related directly anteriorly to the left atrium. Now, posterior to the esophagus is the aorta, as you can see here. It's right posterior intercostal vessels coming out of the thoracic aorta, and the hemiazygous veins behind the esophagus. And there is a topic you should learn about, especially if you became an internist, about esophagoscopy. The esophagoscopy, you encounter constrictions or restrictions when you introduce the esophagoscope along the course of the esophagus. This is because of structures pressing on the esophagus or crossing the esophagus. First, like for example, the junction with the pharynx. This is a narrow area because it's the location of the upper esophageal sphincter, which is the cricopharyngeus muscle. Crossed by where it's crossed by the aortic arch. And all these, by the way, are measured by inches from the incisor teeth. How far is it from the incisor teeth, and you will be able to know the constriction encountered. Like for example, 40 centimeters from the incisor teeth is the site where the esophagus enters the abdomen. It's crossed by the left main bronchus, as you can see here, and this also makes a pressure, and the esophageal hiatus in the diaphragm, which is at the level of T10 or 40 centimeters from the incisor teeth. So this is one thing to put in mind about the constrictions. Other thing is that swallowed objects, especially in children, most probably to lodge at one of these constrictions. And the bad thing is, if a corrosive is swallowed at the constriction, it will slow down. So this means it will cause more extensive damage to the surrounding tissues. This is what you worry about if a corrosive is swallowed, and especially this happens in children. Okay, the arterial supply branches from the thoracic aorta, of course, the artery right behind it. The bronchial arteries take a share, and the ascending branches of the left gastric artery. This is extremely important. The left gastric artery arising from the celiac trunk in the abdomen and sends its inferior esophageal branches through the esophageal hiatus. This means that the venous drainage will go back to the left gastric vein. This means that this is a site of a portosystemic anastomosis, because every single drop of blood coming out of the GIT must pass through the liver, because food is full of toxins. Even the finest food is full of toxins to the body, so it must pass through the liver. This is called the portal circulation. And there are sites of portosystemic anastomosis. One of the sites is the lower part of the esophagus, where you can get in liver patients, especially liver cirrhosis, you will get dilation and congestion of these venous channels, leading to vomiting of blood, attacks of internal bleeding in the esophagus. It's called hematemesis. Okay, the venous drainage is to the azygous and hemiazygous systems, of course, and the left gastric veins. Do not forget the left gastric veins. Innervation, it's all by the vagus, by the way, but directly from in the upper part, which is of branchiometic origin. And by the way, the upper part of the esophagus is mixed skeletal and smooth muscles, different than the lower parts, middle and lower parts, which are purely smooth muscle fibers. The vagi form an esophageal plexus on the esophagus and give rise to the vagal trunks that will go down and supply the stomach, as we will see in the abdomen. Of course, you know that the ganglia, parasympathetic ganglia, is at the organ site. It's not near to the CNS. So the ganglia, all these branches are preganglionic. The ganglia exist in the wall of the esophagus, in the submucosa and between the muscle layers, in the form of submucosal and myenteric plexuses in the wall of the esophagus. We learned that the sensation from viscera is carried by sympathetic, the pain sensation I mean, and the stimuli for pain here are different than the somatic sensations. It's dilation or constriction or ischemia. Okay, and the parasympathetic innervation through the plexuses for the motor function of the esophagus, and the sensory part of it, the parasympathetic, is responsible for the reflexes of the esophagus to what's passing inside. Okay. By the way, the esophagus is always kept closed. The upper esophageal sphincter and lower esophageal sphincter are always closed, except of course when we ingest food, and this creates rather a negative pressure, -5 atmospheric inside the esophagus, that resembles the -5 atmospheric of the pleural cavity, by which the lung uses to withdraw air from the outside environment. Without this negative pressure, we wouldn't be able to breathe, actually. So sometimes you can measure the pressure, intraesophageal pressure, to give you an indication about the pressure inside the thoracic cavity as a whole. Okay? Because it's always kept closed. Okay. The thoracic aorta, the other structure in the posterior mediastinum, begins at the level of the angle of Lewis, at the end, of course, of the aortic arch, and descends from T4 to T12, where it passes through the aortic opening of the diaphragm, as we studied before. It was first to the left of vertebra, then anterior to vertebra, and in the abdomen it will end by dividing into the two common iliac arteries. The branches of the descending thoracic aorta, remember the posterior intercostals, remember the bronchial branches, pericardial branches, esophageal branches, of course, and mediastinal branches to the structures of the mediastinum. And before they leave the thorax, we have the superior phrenic arteries that supply the diaphragm from the superior surface. Okay, now that was about the arterial side. The venous side is the azygous venous system. It's simply a connection of three veins with their branches, with their tributaries. On the right side is the azygos. Azygos starts on the right side in the abdomen by the joining of the subcostal vein and the ascending lumbar vein, and the azygos either passes through the aortic opening or through the right crus of the diaphragm, ascends on the anterolateral surface of the vertebra, as you can see here. Okay, and high up it arches forwards above the root of the right lung and drains into the superior vena cava, draining the posterior intercostals below. Remember, the first part was to the brachiocephalic, and the rest was to the esophagus to the azygos on the right side. While on the left side we have another azygos, but divided into two parts. The lower part is called the hemiazygos, formed by the same union of the subcostal, and you can see it here actually. No, it's a little lower down, of the subcostal and the ascending lumbar vein, descends also either through the aortic opening or through the left crus of the diaphragm, ascends anterolateral surface of the vertebra, and level of T4 or T5 it crosses to the right side and drains into the azygos vein. The same story here for the upper posterior intercostals. They form the accessory hemiazygos, which descends on the vertebrae, and at the same level of the crossing of the hemiazygos, they cross to the other side behind the aorta, of course, to drain into the azygos vein, which is the main vein. This is the accessory hemiazygos here. This is the hemiazygous, okay? And they are variable, by the way. They may be connected as one vein. They may be divided into two systems as the common finding, whatever. But the end result is that the posterior intercostals will be, left side will be draining eventually into the right side, into the azygous vein, and from it to the superior vena cava. Okay, the hemiazygous and the accessory hemiazygous drain esophageal, mediastinal veins, pericardial veins, and the bronchial veins, like the azygous vein on the right side. We talked about the hemiazygous and the accessory hemiazygous. The thoracic duct begins in the abdomen, level L1 or L2, bag or a sac of lymph called the cisterna chyli. It will give rise to the thoracic duct that will ascend through the aortic opening between the azygous on the right side and aorta on the left side, ascends in the thorax and between the azygous and the aorta. Level of T5, it moves to the left of midline, then ascends and joined by the, remember the main trunks we talked about earlier in the head and neck, the jugular trunk and the subclavian trunk and the mediastinal trunk, okay? And eventually it will curve laterally in the root of the neck and drain into or empty into the junction of the internal jugular vein and the left internal jugular vein and the left subclavian vein. And those three trunks on the right side will form a single trunk that will drain the right upper limb and the right hemi, head and neck, into the right junction of the internal jugular vein and the right subclavian vein. There was a question about the thoracic duct, a nice question actually. After a meal, if you cut the thoracic duct, what will you find in it? What's the composition of fluid inside? The answer is, of course, you studied in biochemistry that the main channel for absorption of fats or lipids is through lymphatics by means of forming chylomicrons. It's like the effect of soap on fats that dissolves fats into small particles called the chylomicrons in the intestine and absorbed by lymphatics. So after a meal, you will find a milky fluid actually full of chylomicrons because of the absorbed fat. And what else? If we are talking about white BCs, which type of white BCs you will find there? Well, white blood corpuscles. Which type of cells or corpuscles you will find there? T lymphocytes. So in the T lymphocytes, they wander around the body, but the B lymphocytes for humoral immunity stay in lymph nodes. So the wandering immunity cells, are the T cells, are the ones you will find in the thoracic duct. So the answer would be chylomicrons and T lymphocytes if you theoretically cut the thoracic duct and examine the fluid inside. Okay, this is a question I encountered many times actually in exams. It's a good question. The sympathetic trunks, they descend by the side in front of necks of ribs. So they are not part of the posterior mediastinum, because to be part of the posterior mediastinum, you should be in front of vertebrae. Okay, it has 11 or 12 ganglia, each corresponds to one spinal nerve, and the upper ganglia fuses with the lower cervical ganglia commonly to form the stellate ganglion, if you recall that from the study of the root of the neck. Okay, and remember we talked about the gray and white rami communicantis. The white ramus communicantis is the one that brings the power from the wall terminal. Remember the example, if you are connecting multiple devices to a single wall electricity terminal, so you bring this device with many sockets in it to distribute it to the devices you have. This device with all the sockets is actually the function of the sympathetic trunk. It receives its sympathetic power supply from the intermediolateral horn of the spinal cord between the ventral and posterior horns, and through branches through the anterior root of the spinal nerve, and this branch leaves the anterior root of the spinal nerve and leaves the spinal nerve outside the vertebrae and goes to synapse in the sympathetic ganglia, and fibers go up and down many levels to distribute the sympathetic outflow, and by means of gray rami communicantis back from the sympathetic chain to the spinal nerves to be distributed throughout the body. So if we know that the sympathetic outflow sources are from T1 to L2 segments, spinal cord segments, this means that only the thoracic nerves, the spinal nerves, and the upper two lumbar nerves will have white rami communicantis. But all the spinal nerves from the beginning till the end of the spinal cord will have gray rami communicantis. So the difference here with the spinal nerves, the thoracic spinal nerves, is that they have two connections with the sympathetic chain: the white ramus communicantis and the gray ramus communicantis, other than the ones we saw in the neck, for example. All were gray rami communicantis, and we will see the same case in the lower lumbar and the sacral region of the spinal nerves. Okay, it runs at the side of the vertebra, as I mentioned before. And from the lower ganglia, they give what's so-called splanchnic nerve. See, this is one of the splanchnic nerve. This is the greater splanchnic nerve. See how it crosses to the front of the vertebrae? Now it entered the posterior mediastinum. So to be precise, because I was surprised some books count the sympathetic chain as a content of the posterior mediastinum. This is totally wrong if you are running strictly by the definition of the mediastinum. It should be in front of vertebra, back of sternum. So the sympathetic chain itself is not a part of the posterior mediastinum, but the splanchnic nerves are, because they cross to the front of the vertebra. As you can see here, this is a greater splanchnic nerve, this is lesser splanchnic nerve, as you can see it. Okay? The greater splanchnic nerve from the 5th to 9th ganglia, anterior to vertebra, pierces the cross of the diaphragm. It has its own opening in the diaphragm, and we discussed this earlier with the diaphragm, to the celiac trunk, where the sympathetic outflow will be distributed along plexuses, along vessels. The celiac trunk is the major artery of the foregut, okay? It will be distributed in a plexus around the vessels. The lesser splanchnic nerve from the 9th through 11th ganglia, and also through the cross of the diaphragm, to end in a ganglion called the aorticorenal ganglion near the kidney. And last one is the least or lowest splanchnic nerve from the 12th ganglion through the cross of the diaphragm to the renal plexus. Okay. Now after we are done with the sympathetic trunks, so we're done with the structures in the posterior mediastinum. This concludes actually the inferior mediastinum and concludes our study of the thorax. We'll be starting the abdomen soon, anterior abdominal wall. I hope this lecture was of maximum benefit to you, I wish you all the best, and thank you very much for watching.